Role of the podiatrist, maybe it's by a psychosocial approach. Thank you.
Good afternoon, everybody. First of all, I would like to thank Joao and all the organizing committee and obviously Enpodhe committee for their kind invitation for me to give this lecture today in this conference, which is very much at heart and which I really like always to attend. So today I'll be talking to you about something very different, and in Malta we've been doing quite a lot of research on it. As we were talking this morning, and what the message that I want to pass from this lecture is that maybe as clinicians, as podiatrists, we tend to look at feet, but we tend to forget other important things, which as clinicians, we need also to consider. Because if we do not consider things like low mood, depression, this could affect compliance of our clients. And sometimes it could be that maybe we think that it is our treatment that's not working, but maybe that was not the case. And the case is that there may be something else which is hindering the patient from following our advice. So, okay, sorry. I don't know how. Sorry? I need to tell you. Next. Put that in that direction. Okay, sorry. Okay. So first of all, we know that more than 150,000 people living in the United States undergo amputations of lower extremity each year. We also know that in Europe, an average of 30 per 1,000 of the population have also been reported to undergo major amputations annually. Obviously, as we all know, lower amputations have been reported to be significantly stressful, not only on the patient, but also on their family and on the healthcare system, because it costs a lot. In fact, we do know that sometimes losing a limb has also been reported to be similar to losing a spouse. So many psychological reactions to lower limb amputation may be transient, may be short-lived, whilst others may be perpetual. Several researchers have found that, as I said, the loss of a limb sometimes can be severe as that associated to losing someone from a family. The majority of studies mainly focused on symptoms of anxiety and depression before conducting a lower limb amputation, and very few studies had been conducted actually interviewing and seeing patients after they have had the actual amputation. So I think this is something that we need to reflect on. Again, as podiatrists, especially podiatrists maybe in Spain who do more surgery than us, maybe in Malta and other parts of Europe, we might think that we have a patient who lost a toe. Well, it's not something that big. However, if we look at this disability score, we know that when a person loses a toe, he is considered to have 3% disability. Obviously, as you can see, the percentages keep going up, and when a person has an amputation of the foot and ankle, he is considered to have 50% disability. So, as you can see, losing a toe, part of a foot, is going to bring about a certain amount of disability. So, coming to mental health, we know that the Center for Diseases Control and Prevention, the CDC, defines mental health as a state of emotion, psychological and social well-being, which affects the way in which we feel and we think and we act. There are several mental health disorders. However, for the purpose of the studies that we are conducting, and obviously because we are not psychologists, so we cannot really diagnose depression, we will be focusing mostly on anxiety disorders and post-traumatic stress disorders. So symptoms of mental health disorders can be in reality identified through a number of mental health screening tools. Now I want to emphasize on this, symptoms of mental health disorders and not diagnosis of depression or a mental health disorder. This is indeed very important. So we know that there are a lot of tools, and for the purpose of this study, which I'm going to present, we use the SRQ-20 binomial response, mainly because it is a very simple screening tool to use, it is very easily understood, and obviously the clinicians, most importantly, who are using this tool, do not require a certain amount of training in order to use it. So, coming also to quality of life, the WHO defines quality of life as an individual's perception of their position in life with regards to their culture, value systems, as well as their goals, expectations, values, and concern. And again, for the purpose of the study, in order to assess our person's quality of life, we used the EQ5, the 5L questionnaire, and also in this particular questionnaire, there is a subsection which also looks at anxiety and depression. So, with regards to justification for our study, we know that both depression and anxiety are mental health disorders, which are commonly present in patients who have undergone amputations. As I already said, surprisingly, there are very few studies which have looked at this, especially conducted by podiatrists, so hence the role of the podiatrists in mental health issues. And therefore, this elicited the need to conduct the study in order to assess, as I said, mental health issues among our clients. So the aim of the study was to identify whether there was a significant difference in mental health status and quality of life in lower limb amputees living with diabetes when compared to those people living with diabetes, however, who had not sustained an amputation. And those were the objectives of our study. So obviously we sought ethical approval from the Research Ethics Committee in Malta. We used convenience sampling, and our two groups were also matched for certain variables using frequency distribution matching for variables like age and precision matching for variables like gender, marital status, employment status amongst the groups. So basically in our groups we had 38 participants who had undergone an amputation, and we had another 38 participants who lived with diabetes, however had never sustained any amputations, ulcerations, or any other complications. And this again is showing you the inclusion-exclusion criteria of our study. So we conducted a prospective, matched non-experimental longitudinal comparative study, as I said, with 38 participants in each group, and all participants were subject to the two questionnaires which I mentioned earlier before. So this is just to give you an idea of some of the questions which the SRQ-20 asks, and this, for those of you who are not familiar, are some of the questions, some subscales which the EQ5DL questionnaire asks. So the same group of participants were then were first evaluated 1 week post-surgery, and then obviously the two groups were again interviewed 6 months after the amputation for that group of persons who had sustained the ulceration. Besides recording their mental health status, we also looked at whether they needed a revision of their amputation. We looked at the progress of their amputation site, whether it was still painful, infected, or was healing well. And we also recorded whether, for those people who had sustained the amputation, whether any of them sought psychological help right after that they had sustained the amputation. In order to analyze our data, we used the Shapiro-Wilk test in order to confirm the distribution of the data. As I said, we had a total of 76 participants because unfortunately in the group who had sustained the amputations, we had 2 participants who passed away. We do not know the reason why they passed away, but obviously they couldn't be included in the second part of their study. So we were left with 38 participants in group 1 and 36 participants in group 2 for our second interview. So these are the results of our study. If you look over here at the mean values, you can see that when we look at the amputees, both at time 0 and at time 1, they always showed higher levels of depression than the people, participants who did not sustain the amputation. And we also know that a threshold level of 8 or more suggests psychological distress. So we know, as I said, that if we look at, especially at time 0, right 1 week after the amputation, you can see that the amputees were passing through a period of distress. Same if you look at the mean results for the quality of life questionnaires. We saw a significant difference, very evident, between group 1 and group 2, again indicating that amputees had a poorer quality of life than individuals without amputation, both at time 0 and time 1. And these are more results, again, confirming always the differences between the 2 groups. So, what are the implications of these results? So, the findings of the study suggest that both mental health and quality of life are negatively affected after minor lower limb amputations. Mental health disorders, in particularly, were proven to be present 1 week after lower limb amputation. However, the type of disorder present was not identified. As I said, we can't say that what type of depression they had because we did not look at that. And could only be used, obviously, if we had done a proper diagnosis of the specific mental health issue. So the result of the study suggests that individuals with minor lower limb amputations had also less mental health disorders 6 months after their amputation. So it seems that with time, they started to get adjusted. But that was not only the reason. The reason for these results could also have been because some of them did seek psychological help. Okay, so then after 6 months, they needed psychological help. Again, same implies for the quality of life, especially if we look at the quality of life questionnaire with regards to the category of mobility, which indicated that the early stages of amputations, most participants had moderate problems in walking. Incidentally, results showed that mobility remained unchanged even after 6 months in that specific group. With regards to self-care and other usual activities, they also remained unchanged, indicating that individuals still had minor problems and difficulties in order to be able to perform their usual activities like washing, dressing up, etc., etc. So, the study suggests that even after 6 months, lower limb amputees may still not be fully recovered and have back their independent life. The results of the study also indicate that although minor limb amputations account, as you saw from the first table I showed you, only as a small percentage of disability, comparing to other more serious amputations. However, these individuals still show signs of low mood and depressive symptoms. Obviously, like every other study, each study has its own limitations. So we do know that, first of all, the sample size might have been slightly small. We do know that the bigger sample size, the more accurate our results. However, the study was conducted during the pandemic, and it was indeed very difficult to recruit patients. And also, it could be that since we made use of questionnaires, sometimes we do know that maybe patients do not understand us really well and could have maybe not responded in the accurate way that we really want, they had to respond. So we always need to keep and bear that in mind. So again, take-home message with regards to podiatrists. We tend to look at the feet, we tend to do a biomechanical evaluation, we tend to do a vascular examination, we tend to do a neuropathy examination when our patients come to us. If I had to ask for a show of hands in the room here, how many of us perform a depressive evaluation when our patients come to us? Let's be honest. Can we show a show of hands? No one. Okay? And we know that it's time that we should be looking at this too. Because if our patients are passing through a bad time, it could be that although we are giving the best treatment, we're giving best advice, however, it could be because of the hardship that they are passing through, okay? It could be that it is difficult for them to undergo the treatment and the advice that we are giving them. So we need to take this very much into consideration. This was not the only study. As I said, at the moment we are doing quite a lot of studies with regards to depression and depressive symptoms. We also conducted another study. This time we did not look at amputations, but we looked at one very common complication of diabetes, peripheral neuropathy. Okay, for those of you who are interested, the paper is published in the Review of Diabetic Studies. We found the same results. Patients with neuropathy compared to patients with diabetes without complications did have differences in depressive symptoms. Sorry. So as I said, the aim was to try to determine whether there were signs of depression. And here, if you look at this time we used a different mental health score tool. This time we had used the PHQ-9 score in order to determine depressive symptoms in our patients. And as I said, if you look especially at the bar graph, you can see that the patients with diabetes, when compared to the patients with peripheral neuropathy, showed more signs of depressive symptoms than the other groups. So, again, this is one of our papers which we have published a few years ago. Here we looked at diabetic foot screening guidelines. Again, if we look at the guidelines, they talk about how to screen for neuropathy. They talk how to screen for peripheral vascular disease. They talk about how we need to look at biomechanical risk factors. However, no mention in screening guidelines. This looked at the 10 most common screening guidelines which we use, IWDGF, ADA, WHO guidelines. So again, anyone interested to read this paper, it is available online, but no signs for healthcare professionals, podiatrists, in order to check for depressive symptoms. So, as I said, same as I was saying, mental health disorders, very importantly, must not be relegated to the bottom of priorities in our national health care systems, but they must be given the importance of that they deserve. We did see a lot during COVID times how much depression did increase amongst our clients. We saw very much during COVID times how much our patients deteriorated. I don't know what happened in your countries, but in our countries, our amputation rates increased during COVID. I don't know in your countries, but in our countries, we saw for the first time again maggots in the wounds. okay, which we hadn't seen for a very long time. Why? Because people were in their home, they were depressed, they were closed, okay? They didn't go to the clinics because they were afraid, and they deteriorated. So, as I said, mental health disorders must not be left to the bottom of the list. This current paper, which I spoke in detail about, should be out soon. It will be published in the International Journal of Lower Extremity Wounds. As I said, mental health, this is the message I really want you to take home with you. Mental health matters must not be relegated to the bottom of priorities, both in our clinics, but most importantly, in our national health systems. They need to be given their importance. Thank you very much for your attention.
Thank you, Cynthia.